Welcome everyone this morning. My name is Dr. John Jeans and I am an anaesthetist for a couple of days a week who tries not to eat cake in theatres when it's available. And when I'm not anaesthetising, I lead the CLEAR programme nationally, and I'm really pleased to be see everyone on the call, and very pleased for this session to be joined by Emma and Claire. Just a little bit of housekeeping before I go into the details of the webinar for the next 45 to 50 minutes. Housekeeping. If everyone could turn cameras off for the presentation, except for the people who are speaking. If anyone has any questions, please do not hesitate to put them into the chat as we're going through the presentation. We will have two short breaks for questions after each segment of the presentation, and what that will be is stopping to say, does anyone have any questions? And we'll wait for about 5-10 seconds, and if no one has any questions, hands don't go up very quickly, we will then crack on and continue, but then obviously have a longer space for questions at the end. Without further ado, I will crack on and pop some slides up, do some true formal introductions for Emma and Claire. But before I do that, can I just check, can everyone see my screen? Okay, yeah. Wonderful that is working. So as I said earlier, my name is John Jeans. I am an anaesthetist and lead the CLEAR programme nationally, and I'm very pleased to welcome Claire Brewster, who is part of the CLEAR National Faculty and a practicing frailty nurse in Calderdale and Huddersfield. And I'm also really pleased to welcome Emma Maguire today, who's a dementia case manager at the Healthy Hyde PCN. Thank you very much, Emma, for taking some time out of your busy day to present today. Just for context for everyone on the call, the CLEAR programme is a national programme hosted at East Lancs Hospitals Trust. It's delivered by the Trust and 33N, and is commissioned by Health Education England, NHS England, and a range of other national and regional bodies. The topic of conversation today is the impact of CLEAR and the findings and learnings from some of the projects that we have done over the last year or two. It is important to say that to really go through all of the findings and learnings from all of the projects, it takes days and weeks, if I'm honest, because there's so much rich information and really positive change and transformation that comes from each individual project. So what we will do is go through some of the key, the highlights of the work that's been done over the last 18 months. And we'll do that with Claire, firstly going through some of the impact and outcomes from the UEC projects that finished earlier, in the last calendar year. Emma talking about some of the brilliant work that she did with colleagues in Hyde, and then with proactive care and anticipatory care, and then I'll then go on to discuss some of the work that's been done in primary care, ophthalmology and theatres at a very high level, along with some of the economic evaluation, and then we will finish for questions. So without further ado, I would like to hand over to Claire to talk us through the Urgent Emergency Care Programme and key findings and learnings. Over to you, Claire.
Thanks, John, and morning, everybody. Thanks for joining us today. So yeah, I'm really pleased to just go through the programme, the key findings and learnings that we did with our urgent and emergency care sites within the country. So we can just go on to the next slide, John. And as we know, improving urgent and emergency care is a national priority in the long-term plan, and the aims of the delivery plan for recovering UEC services are to reduce waiting times, improve urgent care in the community, avoid unnecessary hospital admissions and speed up discharges. We started this work before these priorities were published earlier this year, so we've got some information back from our pilot sites in 2019, and I'll just talk a little bit about those this morning as well. Let me just go on to the next slide, please. So within the CLEAR programme, we've worked with 10 hospital trusts, and we did pilot phase back in 2019, and we had 6 trusts that joined us then, and I was lucky enough to be part of that pilot with Calderdale and Huddersfield. We then moved on to phase 2 back in 2021 and 2022, and we worked with 4 trusts there and looking at all their urgent and emergency care activity within their A&E departments. What we found with the challenges, if we can just go on to the next slide, thank you. The challenges in all of the trusts that we work with, and as I think we all know, is that there's been a great increase in the number of patients attending ED over the last 15 years, whilst inpatient bed numbers have declined. And we've also got increased pressures across UEC and record numbers of patients waiting more than 12 hours for admissions. Within the sites, there were really 4 key themes that jumped out to us all, really, both associates working on the sites and people within the CLEAR programme. And that was around congestion in ED, causing long waits, performance challenges and low staff morale because they've got patients in the department and more patients arriving and there was nowhere for these patients to go, so care was compromised. Misalignment of streaming pathways, so we're underusing. We had pathways in place and we had areas that we could send patients to, such as SDECs and clinical decision units, but there was noticeable underuse of these pathways and these areas, and that was obviously hampering patient flow and resulting in poor patient experience. There were also challenges in managing high volumes of older patients living with frailty, and we'll talk about that in the case studies that we've got. But again, that caused prolonged length of stay in ED and high admission rates, and these patients are complex. They need to be nursed on trolleys. They've often got dementia and a delirium, so they're quite challenging for the staff to look after in the departments. And then ensuring that clinical staff have the right skill mix for patient cohorts. So the skills and experience are not always aligned to patient needs, and I think we've all noticed, especially since COVID, that patients are getting more complex since COVID, and they've got a lot more comorbidities. We'll just move on to the next slide, John. Thank you. So the recommendations, high level, every site had their own specific recommendations and they were able to look at their estates, processes and workforce individually. But our high level recommendations that we got from the UEC work was new models of care and ways of working and how we could help the sites to improve the quality, safety and effectiveness of patient care. Some of those examples are older persons ED and looking at SDECs for frailty patients. Some of them were looking at new early assessment processes for walking adults, so looking at how we could stream patients better, how we could work more collaboratively with our GP partners and community staff, and how we could look at triage and treat areas, so fit to sit areas, for example, for well walking adults, and how we could look at the minor case loads of patients that were coming into departments. Looking at the workforce, we looked at new skill mix and how we could broaden and support staff and get the skill base of staff, enabling colleagues to work in a more flexible way, but also new ways to meet patient needs and to relieve pressures of workforce. Within that area, really, we looked at roles such as advanced care practitioners and AMPs, EMPs as well, so they're upskilling those to treat minor illnesses and how we could stream the patients arriving in the department to those areas so that they saw the right staff at the right time. We also looked at discharge pathways. We looked at patients who were able to assess priority walk-ins, and we did a lot of work around multidisciplinary team working as well. So how we could kind of use other colleagues that worked within the department or within the hospital and how they could support the departments in working more efficiently and improving quality of care for patients. As I spoke about, we did talk about new roles and introduce new positions to ensure high quality care, easing pressures and optimising pathways. One site looked at introducing a longer stay nurse, and that was for patients who'd been in the department, I think, for over 6 hours, definitely over 4, but I think they looked at kind of the 6-hour wait. So they were like quality nurses that would go around and do quality checks for the long stay patients that were in the department. The use and introduction of discharge facilitators, and they were staff that would help staff in ED help to discharge their patients. We also looked at care navigators, so they would support the nurse nurses in charge of the flow of patients in the department, and there was a lot of work around frailty and how the frailty services and frailty advocates could support the patients who were in ED. Go on to the next slide, John. So the forecast impact, some of the predicted productivity gains of 10.5 million for NHS trusts involved in phase one were seen, and that was really kind of powerful when we kind of got all the work together and how we looked at how we could improve changes and what it would mean for each trust involved. For phase two trusts, we looked at £4.5 million worth of savings expected if the trusts were able to introduce and implement all the recommendations that we made. Reduced overcrowding and congestion, reduced length of stay for patients in ED, and how we could reduce up to 50% of unnecessary admissions for older people living with frailty. And I think, you know, combining with the national targets that we've got and the new national initiatives with the UCRs and virtual wards, this is really, the work with CLEAR has really enhanced the trust to be able to incorporate new services. What we're all here for is to improve patient care and experience, and the work that CLEAR did really did enhance that, and the staff on the floor really felt that the changes that were introduced and recommended, because they were from clinical staff and clinical teams working there, they really felt that these changes would be implemented and embedded really quickly. And along with that, really improve staff satisfaction, morale and retention. Around 70% of the recommendations made during phase one of the programme have been implemented, and implementation of phase two recommendations is still ongoing, but we do know that there have been some embedded and implemented. And we've just got a quote from one of our doctors that were involved at North Mid, and he just said, having CLEAR fellows in ED helped to inform and guide the improvement efforts of our ED. Their influence and our strategic thinking is evident 2 years later. So I'm just now going to talk about a couple of case studies from our UEC work, and this one is down in Hampshire on the south coast. And they were a non-trauma receiving hospital, and they had real issues and challenges with their front door streaming and triage processes. All the patients arrived on one, all the walk-ins were just seen by one nurse at the point, and we went down and did a site visit, and patients were actually queuing outside down the road on some days, waiting to be triaged and assessed at the front door. They also had another challenge of a high proportion of frail patients were waiting over 90 minutes for initial assessment, and many were fit for discharge within 24 hours, but transport difficulties resulted in high length of stay. And we actually had a paramedic working with the Hampshire team on the CLEAR programme, so that was really, really useful for us to collaborate with the ambulance service in Hampshire. So what they recommended was improvements to the streaming process. They looked at how they could improve streaming for patients who walked in, how they could upskill existing EMPs to see and treat minor illness patients. And then they also recommended the creation of a dedicated frailty zone within ED so that they could, the existing frailty teams could support the ED and they had a place to work rather than the patients being scattered all over the department. We looked at the workforce, and there's a table there just showing how we upskilled the MPs for the minor illness service. But what the impact really was how we could enhance productivity and efficiency at Hampshire. And the figures there are really, they're really powerful. So there was a potential to prevent 6,900 admissions of frail older patients with a savings of over 3 million. We were enabled to upskill the staff to train in minor illnesses, and the training for the MPs to progress to ACP level in line with national practice was really encouraged and at the site. We were able to highlight that we were able to release 6 full-time equivalents of medical time, along with improving patient satisfaction and reduced length of stay with those with minor illness, and embed system-wide working. We had 2 Band 7 sisters on the programme along with the paramedic, and the clinical support was a matron from ED. So it was all very much clinically led, and the changes came from the team at Hampshire. We'll just talk about the next site, which is Kettering. And Kettering, they'd already undergone some significant changes in its estate as part of COVID-19. Site was phase 2, so this was kind of post first phase of COVID. They were also again found that they had some challenges around minor illness and minor injury, and also frail patients waiting a long time in A&E. We found that the patients that were suitable for SDEC weren't being transferred across, and there was some challenge around why that was happening. So what they recommended was an ambulatory pit stop model, and that was for the rapid assessment of all priority patients and they opened 3 rooms in majors Monday to Friday, 8 till 10. And the data that they were able to look at showed that that was kind of the peaks and troughs, and they were able to open these areas in response to the data that they found within the CLEAR project. What they also recommended was the development of a nodal assessment unit for fit to sit patients aged 65 and above. And again, this was a 10-seated clinical area that all the patients would be streamed into that area, and specialist staff would be able to come then and assess and work with the patients to try and get them into the right place. Again, impact-wise, the introduction of the pit stop model, we forecast the reduction in admissions resulted in a £423,000 savings. And that also helped with prompt assessment of priority patients with early senior decisions and improved access to SDECs, faster downstream assessment. So it was an improvement in flow, and having those senior decision making at, at that early stage of the patient journey just reduced length of stay. We also found that there was a reduction in the number of medical investigations performed if the patients were seen by senior decision making at that stage, and improving staff and patient experience. For the older assessment unit, improved patient experience with a reduction in waiting times and a reduction in risks for these patients being in hospitals. And the one thing that they really wanted to focus on was the falls in ED, because they found that they had a high level of falls for the elderly patients in ED. Enhanced discharge process with early therapy assessments, how we could get therapy working with ED staff more effectively, and how they could look at the referral process for that. Reducing admissions out of hours and improve staff experience with increased educational opportunities. And again, the team at Kettering, we had nurses from the ED department supported by one of their consultants who did the programme up there. So that kind of, the workforce mix is on there with the redesign of the expansion of the team. A lot of it was the staff were already in post, but it was how we could rejig it to work more effectively, and how we could move staff over to these areas and put them in the hours where the demand was there. So the data was able to highlight where the supply and demand was for the patients and activity. Thanks, John. I think I was just then going to talk about Calderdale and Huddersfield. We didn't prepare a slide for that, but I'll just share my experience of working at Calderdale and Huddersfield with our urgent and emergency care. And we were one of the pilot programmes back in 2019. So this was pre-COVID, where all the estates were still traditional, and we had an SDEC unit that was underutilised. We had a frailty team in. It was quite a dynamic, well, it is a dynamic trust with good leadership. We had a really good frailty service in post, but there were still challenges, and there were still areas that we knew that we could improve. So CLEAR came along, and we were able to actually just really dissect what was going on in the department. We were able to extract the data for 5 years of A&E activity, so we were able to look at the patients coming through the door, when they came, when the demands were, and able to look at the cohorts of patients that were coming through. So we kind of found that we had a real high breach rate and real long length of stay for out of our patients, and that was for minor illness, but also for the elderly workforce. What we did, we looked at streaming like a lot of the other trusts did, and we put band 7s at the front door, so there was senior decision making, they had the autonomy and the clinical skills and expertise to assess patients who walked in. And they did a lot of work with the GPs and some wider collaboration around how they could re-refer the patients back out into the community and work at how they could look at supporting patients getting the care that they needed. We also looked at the frailty pathway, and the service was an 8 till 8 service, 7 days a week. But what we found was that most patients arrived at between 5 and 6 p.m. So they weren't really always being seen by the frailty team because they'd finished. So we actually extended the service of the frailty team till midnight, and so they were working 16 hours a day, 7 days a week, and that has had dramatic effect on length of stay within ED and also performance. We've introduced post-COVID, we've introduced an SDEC now, and we've got a greater range of staff working within the team, especially around the ACPs, therapy teams, pharmacists, and also working with virtual ward and UCR teams. So now we're getting patients directly referred to SDEC from ambulances, so they're bypassing A&E. And we're also doing a lot of work with the ambulance crews, taking handovers from ambulance crews as the patients arrive in ED. So that's kind of Calderdale and Huddersfield story, really, from a personal perspective. And I'm just going to now move on to anticipatory care, because I led the programme that we did last year that Emma's going to talk about her work. But just to give a high-level overview of what that work involved last year, and we were asked to look at some anticipatory care, proactive care, within working with PCNs in England. And the 5 PCNs that took part, we had 3 up in the north, so we had East Warrington, Tabor and Hyde PCN that joined us, and then we had 2 in the south, 1 in Camden and 1 in Regis. And this was a 26-week programme that took place between January and July last year. We had associates from all the sites that worked with us, and that ranged from nurses, GPs, we had a social worker, and we also had some paramedics on the course that were doing the AMP programme. And the clinicians from each PCN were trained within the CLEAR methodology, and they went on then to look at work within their PCN. Again, high-level overview of what we found and what the recommendations were. Probably all that any external people on the call will recognise is that communication was a real recommendation, how we could work more collaboratively, working more multi-agency, using common language, and how we could support carers as well at PCN level. The intercollaboration was with the ICB and ICS level, how we could look at record sharing and multi-agency working, data sharing, system design and demand, and how we could use existing tools more effectively, how we could understand local needs and challenges, and how we could empower the community to take responsibility and look at population health and health inequalities at a local level. And then how we could support with workforce changes, so how the new ARS roles linking in with the ICS and proactive care planning and upskilling. But yeah, how we could kind of reduce the demand on GPs and GP surgeries and the appointments, and how we could redirect and change the traditional GP model to a more multi-agency and multidisciplinary model within PCNs. I think, is it Emma? Yeah, so I'm really pleased to introduce Emma Maguire, and Emma worked with us at Hyde, and she'll talk about her work now and how they've actually been able to implement some of the recommendations into practice.
Thanks, Claire, and thank you for having me. Good morning, everybody. So as Claire just said, I took part last year in the CLEAR Anticipatory Care Proactive Care project for Hyde PCN, and I think the first slide might be a little bit of site-specific information. Yeah, so just to give you a little bit of background about where we are, Healthy Hyde PCN is based in the borough of Tameside in Greater Manchester. The PCN is made up of 8 GP practices. We have around 72,000 patients that we cover. Hyde itself is a fairly deprived town. Nearly 50% of our population live in some of the lower layer super output areas. Life expectancy is lower than national average, and we have high levels of smoking and comorbidities, dementia being higher also than the England national average. As we were saying, anticipatory care, proactive care is very much about identifying people who were vulnerable and at risk of unwarranted health outcomes. And in Tameside, fingertips data for that time, I think it was 2019, 2020 data showed that the old CCG area of Tameside and Glossop was worst nationally for standardised mortality for those with dementia aged 65 and over, and third worst nationally for unplanned and emergency admissions. So these people weren't just at risk of unwarranted health outcomes, they were clearly experiencing unwarranted health outcomes in our area. So the project scope came down to supporting people with a diagnosis of dementia who were not living in care homes. Brief rationale for that was that the work I was involved in at that time, I was a complex care nurse working in the enhanced health in care home stream of the DES, providing ward round support in care homes to optimise the health of people living in placement. So those patients with dementia living in care were already receiving coordinated, focused management of their healthcare. If we can move on to the next slide, please. So we engaged obviously in the 4-stage CLEAR methodology Claire mentioned earlier. We identified our local stakeholders and undertook clinical engagement with them. The key themes, as Claire said, really quite often, time and time again, communication was top, with people describing poor communication between organisations, repetition of work, poor knowledge of the services and the roles that were out there to support those living with dementia. There was a lack of collaboration between those agencies and services working with our patients. There was inequality of care. So it was perceived that patients who lacked capacity had different journeys to those that didn't, sort of more at a secondary care level, going into hospital. As Claire said, they would be at risk of sort of unnecessary investigations or extra investigations because baseline information wasn't known at the point of entry into the service. And then there were accessibility issues as well, with restrictive referral criteria and sometimes location of services, meaning that patients couldn't get the support they needed at a time when they needed it most. So we took our qualitative themes and moved into the next phase of the methodology, which saw us taking data from EMIS through a dashboard to triangulate findings and see if what was being said out in practice qualitatively was being reflected in the figures and numbers we had through our EMIS dashboard. So we identified there were 664 people with dementia living in our PCN at that time, an almost 50-50 split between care and their own homes. What we did see very quickly was that people living in their own homes were having double the number of GP appointments when compared to very similar numbers living in 24-hour care with dementia and very similar comorbidities. Patients that were in the care homes were also having greater exposure to allied healthcare professionals and a wider MDT input into their health management. And this was thought to be because of the work the complex care nurse team were doing in providing health optimisation for people living in care homes, which at that time people living in their own homes didn't have access to, so there was that inequality. One of the findings from qualitative data was it was really quite difficult to access our local mental health service team at a time where people with dementia were having a crisis. That came through from our social care colleagues and some of our GP colleagues that we couldn't get access to those mental health workers when we needed them the most, and it certainly reflected in the figures that just 23 referrals were made for a patient group of 664 with dementia, and there are some very quite challenging patients in our care homes. We have 13 care homes in the Healthy Hyde PCN, so we would have expected referrals to the dementia practitioners to have been much higher. So we set about the next phase, and the next slide please, John, which was innovation and thinking about what could we have in an ideal world that would help support people living with dementia at home. And we came up with a recommendation for a dementia case management service. So that would give patients of the PCN a dedicated healthcare professional that would establish connection and contact, providing proactive care through focused coordination of complex needs. So utilising the wider MDT, involving stakeholders, being an umbrella to a patient's journey, where traditionally that might have been the GP in time gone by. That doesn't happen anymore, and people quite often will just move between services in our area without very much consistency and collaboration. People don't know that mental health have been involved, or that a patient's presented at ED until a week later, and what might be happening. So it was to close some of those loops, coordinate care and focus a person's needs, but working with patients and families, looking at strengths, independence, trying to help people live well for longer. I think trying to manage expectations, certainly in my experience so far, expectations of patients and families haven't either been well managed, or there's just not a lot known about the progress of dementia and what can be expected in a person's journey. So the role was, the recommendation was for 3 nurse case managers, supported by a care coordinator from the R's roles. At the moment, we have gone live with a service in January this year that doesn't involve 3 nurses, sadly. We're piloting it. It's myself and a care coordinator with just 1 practice at the moment. But the pilot is going exceptionally well, and I've been told this week that there is going to be an extension of that service. We are rolling it out across the PCN. We are recruiting to more nurse or healthcare professional manager, case manager roles. So far, setting up, we came up with, as part of the recommendation in CLEAR, a sort of a triage, if you like, of how we can, where to start with our patients. Do we look at the newly diagnosed? Do we look at the later stage that might be actually having more unplanned episodes and are at more risk? So we devised a red, amber, green, or RAG rating triage system. And in CLEAR, it looked very different. In the ideal world thinking, we considered Rockwood and ED presentations, GP appointments, capacity, domiciliary care, did a person live alone? But actually, when I came to apply that into practice in January, it wasn't easy to do. Some of those criteria weren't readily available in EMIS, and I've made lots of connections now. I'm working really closely with social services and mental health to try to find out more of that information which is coming through. But when I took Rockwood, I looked at Rockwood scoring, but it wasn't a very reliable indicator, because I found I had people that were, for one example, I have a lady that's a Rockwood 5 who'd had 51 GP appointments from October last year to January this year. And then I had Rockwood 7s who had had 2 in the same period. So we couldn't really use Rockwood. So we devised a red, amber, green based on high intensity of GP appointments. So to put it into context, a red patient has had 10 or more in the last 3 months, and the average number of appointments in that cohort is 15.2. An amber patient has had 3 to 9, and the average number in that group is 5.6. And a green patient's had none to 2, and that's an average of 0.7. So I started with the reds because they sounded like they were taking the most of our GP time up. Then we wanted to create capacity, and I've devised a care plan, if you like, an initial assessment that I do on the first visit. That's been derived from work I'm doing, thanks to CLEAR and getting out there with Dementia United, who are Greater Manchester's integrated care programme for dementia. So we're working on a wellbeing plan that's going to go on GraphNet, the Greater Manchester Care Record. So I'm completing that with patients. I'm using the QOF data, the things we need to collect for QOF, and also a bit of a mini comprehensive geriatric assessment. So that first appointment, I'm collecting lots of information, getting to know the individual and their family, and then using that to sort of then go forward with proactive engagement and regular contact. They're already reaching out in reverse to me, which has been great, and I've been able to back some of the work that would have traditionally gone to the GP. At the moment, I think I'm generating more work potentially than I'm solving, and I think when we've looked and reflected on that, I'm a relatively new prescriber and clinical examiner, and I still seek high-level support from the GPs. So I think as my skills and confidence grow, I will refer less to them, and remembering that a lot of these patients haven't had this level of assessment ever, never mind since the dementia diagnosis. And I think that, you know, with that, I'm finding things that I need the GP support with, but those, once they're in place and managed, I'll be moving forward and reducing that GP workflow and workload. Yeah, I'm quite confident that that will happen. Already in terms of mental health, the dementia practitioners and us and I have set up a monthly MDT with our matron to be able to collaborate care across not only people living at home with dementia but living in 24-hour care. So that's come out of CLEAR, definitely much closer working. And as I say, the work we're doing with Dementia United in terms of the wellbeing plan to get that onto a shared platform to further share our patients' information and make their journey smoother. So far in terms of quality for patients, I'm getting great feedback that it's really nice to have somebody that we can reach out to. They've felt lost, lonely, without guidance since their dementia diagnosis. A lot of people sadly don't know there's so much going on. I've found so much more than I realised was happening in our area, and I'm now able to utilise that, and certainly I'm doing lots of social prescribing referrals and things like that, and that's definitely something that's enriching patients' experience as well. So yeah, so far positive implementation, I think, and the fact that we're going to roll it out further across the PCN is really encouraging. I think that's all I've got to say, unless anyone's got any questions for me.
Emma, that was lovely to hear your experience there.
Thank you.
We will do a quick pause for 15-20 seconds to see if there are any questions, but just one from me, just as a bit of this is sort of almost a challenge to myself, so keen to hear your view. A lot of the things that you've done, okay,
Yes.
is the kind of things that people, so I get this a bit, so a lot of this stuff, we should all be doing it anyway. Was there something, and it's okay to say no to this, please, like, was there something about doing the CLEAR program that opened some, what was it about doing, you referenced the CLEAR program has helped you do or engage in some of these activities. What was it about doing the program that helped? Or not, as the case may be.
No, it definitely helps. So doing the program definitely. So I think from a professional sort of experience perspective, we knew potentially what problems we were facing without necessarily doing a clinical engagement phase or something like that. But what CLEAR did do was give us the time and the tools to find that evidence. How do I go out there and find the evidence that it's all right to say, I'm pretty sure we could do this better. I'm not sure how we can do it better. And we know that things are bad because everyone's up at the hospital when they shouldn't be. And CLEAR gave us the evidence we needed, I think, to take to the PCN and say, we'd like to look at a new way of working to support people living with dementia. And this is why, this is what our clinical engagement phase has shown us. This is what our stakeholders are saying. This is what our data says. And this is what we think can fix it. And I think it was better received, instead of you kind of just having a little bit of a moan potentially that things aren't working. So yeah, I think CLEAR definitely being a sort of an evidence-based program really helped us. And it gave us the tools as professionals, myself and Melissa, who is obviously with me today, to be able to have those conversations and for us to be taken seriously, I guess.
So in effect, it's sort of tools, training, and time. If I'm going to be a bit glib about it. Okay.
Absolutely.
No, okay, that's really helpful, Emma. Thank you. And it's just I've not asked that question before, so I just want to do that. And apologies, Chris, because I see you've asked a question. Turn your camera on. Did you want to ask the question in the chat right now?
Oh, you're on mute, Chris.
Yes, if that's okay, thank you. Hi, Emma. Thank you for that. I should declare who I am, shouldn't I, Emma, really, before I answer the question. I'm the clinical dementia lead at Pennine Care Trust, which provides a lot of people's mental health services that Emma's talking about. I think this is a really good example of how what I would describe as an improvement project to effectively establish a liaison role in dementia between primary care and secondary mental health services can pull services together. But yeah, I'm intrigued, and you don't need to answer the question now, Emma, but I'm wondering what the reluctance was to make referrals, whether it was a reluctance or whether it was poor acceptance, because we do have specialist dementia practitioners in our older people's mental health services in Tameside, which is quite unique across our whole footprint as an organisation.
And they're very good as well.
Yes,
they're very good.
Absolutely, but obviously there was some breakdown either in confidence or communication, and it feels like that this dementia case management project has plugged that gap.
Yeah.
Which I think is the real benefit of the project. That it is demonstrating that real coordinator of care role, and making sure that people have access to the support that they require. But yeah, I say you don't have to answer the question now. I
Absolutely, I can. I'll tell you, it was a bit of both actually, Chris. So there was rejected referrals, and I think we talked about the quality of some of those referrals and the timing of some of those referrals. And then there was a perception by some people that were referring that I'm not going to get my referral accepted, so I'll circumnavigate somewhat and try and deal with it in an alternative way. So it was a little bit of both, but I think certainly Hyde PCN and the nurses that probably do most of the referrals into your service have certainly got much better now at making sure that the quality of that referral and the timing of that referral is right. And I think as we continue to work together, that will only get better.
You probably hit the nail on the head. It's about identifying what the need is, isn't it?
Yes.
I think most older people CMHTs will decline a referral if it just says is in crisis, needs support. It's like, go away, come back and tell us what the problem is and what you've done about it so far.
Exactly.
So that makes a lot of sense. Thank you.
Yeah, no problem.
Emma, that's really helpful. Are there any more further questions or comments that people have before I crack on with the last bit of the webinar? And thank you, Chris, for your question. Appreciate it. Okie dokie. In that case, no quick hands. I will crack on with the last little bit of the presentation. And we'll do the safety check. Can everyone see the slides? I'm not hearing anything.
Yep, we can.
Brilliant. Okay, brilliant. Fantastic. Thank you. So I'm going to rattle through these slides relatively quickly. But if anyone does want to have them in full, please just drop us a line. I'm very happy to share. As some people on the call may know, the reason that I got into this work was because my dad got pretty crap care about 7-8 years ago, and from his diagnosis to his death from gastric cancer, most things went wrong, and the only reason that he got what I would call 2000 style care, he died in 2013, was because I was in the system and I was a doctor in the system, and I was able to nudge him through to try and get him the best possible care. What that means in practice is that when he got diagnosed with gastric cancer, if he'd gone to his local hospital, his 5-year survival from any operative intervention would have been 15%. Because I knew some colleagues who were doing some really great stuff in a hospital 10 miles down the road, he got seen by them, and the 5-year survival from that particular team was 50%. And my dad was very fortunate to get a good operation. He ended up sadly passing away 6 months later, and his palliation wasn't handled particularly well. And I was very upset by the whole process, and I was at risk of becoming a grumpy anaesthetist. Not that anyone here has ever met a grumpy anaesthetist. We don't exist as a profession. And for me personally, I've been on a bit of a journey for the last 7-8 years, of which 3 to 4 was trying to understand the NHS and try and understand why things like what happened to my dad could happen. A bit about why we didn't use data to its full potential, and a bit about why, going back to Emma's point, where we knew where the problems were, but we didn't necessarily know how to get the change put in place so that we could improve the care for our patients. And I was very fortunate after doing some work in a couple of different hospitals alongside my own, that HE gave myself and other colleagues the opportunity to create a program to train clinicians to use a combination of big data analysis and qualitative techniques to redesign models of care and workforce to improve patient care and outcomes. And that started with a pilot of 6 UEC sites in 2019. As you can see by the graph or the map on the right, has now expanded more broadly and is encompassing more than half the ICBs across the country. And the program did get a bit railroaded by COVID, as many other programs did, and we had to adapt and change. Part of the work was involved. We repurposed in 2019, 2020 to take the training element of a course and support operational redesign for COVID-19. Trained a whole range of staff across the country. I think it was sort of 2,500 people in total we supported with redeployment. And what's happened since COVID is that the program has kind of grown even further. We've now done 40 odd projects across the country, across urgent emergency care, mental health, primary care, ophthalmology, and theatres, amongst other clinical areas. And obviously worked with a range of different people like Emma and Claire and other colleagues to help people support or deliver the change that they want to within their own organisations. The people outcomes are quite seem to be reasonably positive. We've put 50 people through the fellowship programme, nearly 50 people through the fellowship programme, and generally that's supported career progression, and career progression made their jobs more provided upskilling, and also made jobs more made their jobs a better place to work and enable them to enjoy the NHS more. So it's the program has gone from a pilot through to a fully fledged program now, and it's quite exciting to see and hear the experiences of everyone who's gone on the program. Obviously, as a program, we have a lot to learn. We're learning all the time, and we need to tweak and improve as the NHS tweaks, as the NHS changes. But it's good to see the personal stories and the gains that people have from taking part and working with us. What I'll do is briefly go through a couple more case studies just to give a flavour for the breadth of the program and the impacts that I had. So this is a case study from a PCN that was struggling to deliver same-day urgent care for its population, and some of the challenges that it faced, this is down the southwest, were that really high locum spend. It had risen phenomenally over the last couple of years, as well as an inability to be able to provide all of the access that was needed for their patient population, especially for same-day urgent care. This had led to significant health inequalities and meant that people from lower deprivation deciles were attending A&E more than would otherwise be expected. Excuse me, I've just got to have a little cough. I've got a lurgy from my little one. Bear with me one sec. My apologies. And this was also, and so significant action was needed to try and get the support primary care get back on its feet. And what the solutions were optimization of acute services, specifically in ophthalmology and pharmacy, enhanced triaging to make sure that patients went to the right place at the right time to reduce the number of contacts. Integrated, there's a same-day urgent care hub, and having GPs work in a more consultative role there, as well as optimizing the R's roles with specifically the introduction of first contact practitioners, as well as use of mental health practitioners, as well as mental health practitioners. The other thing they're looking to do is implement some AI technology to manage skin lesions more effectively and to work more collaboratively across the PCN to tackle health inequalities in a coordinated manner. There's been a recent ophthalmology project which has was down on the south coast in the Sussex Eye Hospital, and the project has figured out, the team at the site has figured out a way to significantly reduce the amount of cataract operating lists by increasing throughput, streamlining the triage process so that the right patient goes onto the right list, and enhance the training of doctors and staff, junior doctors and staff who are performing these lists. What this allowed is a significant freeing up capacity and reduction in outsourcing of this activity to the private sector, so that the trust can now repatriate all of the cataract work that was outsourcing back into the trust, so enabling the NHS to recognise more income. The organisation also developed a new way of referring patients in to lower the imaging costs and share images more effectively, and also derived a new workforce model to look after glaucoma patients that minimised the amount of consultant input that we needed to engage with primary care more effectively, to allow optometrists to manage stable patients, allow optometrists to manage stable patients more. And what this enabled was a reduction, what this will enable is a reduction in the backlog from 7,000 patients to none over the next 18 months, and also reduce the amount of avoidable sight loss that will happen if these patients aren't managed comprehensively during that time, by at least 150 patients a year. I'm conscious of time, so there's not going to be 2 case studies. There'll just be one in elective care, but there was a project done at East Sussex which looked at how to increase productivity in theatres. The key challenges, as we all know, is that there were some systems and processes on some legacy IT architecture that meant that it was quite difficult to book and cancel patients and move patients around their lists. There was issues with hospital capacity because patients are more complex and more difficult to discharge, and the system is quite gummed up in terms of discharge processes, and also challenges, as we all have, with workforce recruitment and retention. Although they had some local challenges there that made it a bit more difficult. What the trust did is redesigned how they booked patients to minimise the number of same-day and near-notice cancellations, as well as implementing a 7-day physiotherapy service and instituting new technology to by the form of a platform called the Care Coordination Solution, and all of this is enabling the trust to realise a 10% or conservatively 10% productivity gain, as well as a reduction in hospital length of stay. I never was. If you'd asked me 5 or 6 years ago, how much does economic evaluation matter, I would have said, oh well, I'm not sure of how important it is. As I've done this work more and more, economic evaluations do matter, and we have to make sure we are delivering value for money, both with the projects that we do, in the CLEAR projects we do, but also as a programme. And we're very fortunate to have a recent economic evaluation of the programme, which shows that by utilising the approach and supporting colleagues like Emma and Claire to have the right tools, trained in time, there is a reasonably strong economic case that this work delivers a return on investment, and as well as improving care, empowering staff, it also generates value for money. And for me this is very reassuring, because we all want to help the NHS improve in the most efficient manner that we can. I'm very, very conscious of time, so what I'm going to do is just flash up some of the current projects that are ongoing, and there's a range of different work around urgent emergency care, elective recovery, frailty, and capability building. But I'm just going to pause and come off my screen and just see if there is anyone on the call that has any questions or any comments that I'd like to make at this moment in time. And before I do that formally, I'd just like to thank Emma and Claire for their time in presenting their experiences as well. So on that note, does anyone have any questions or comments or thoughts? And either written in the chat or to Emma or to Claire. I'll wait for a minute or two. Annabelle.
Hey, oh, sorry, I also got a bit of a cough at the moment. I just wanted to say about the point of the kind of personal impacts for people who come on the project. I've worked a lot on the mental health theme for CLEAR, and several of my colleagues on that theme have got promotions or changed the direction of their career, and they've attributed it to the experience they've had through CLEAR. And actually, I got an email from somebody yesterday saying, you know, she's actually got a promotion, and she thinks it's due to CLEAR, and I think that's fantastic. And people are also using some of the techniques that we, help them learn during the programs, and I think that's something that's not to be underestimated. I think, you know, building that sort of capability to work in a different way in the NHS, I think, is really important.
Thanks, Annabelle. I completely agree with you. I was a very, very different type of person as an anaesthetist 6-7 years ago. A little bit more grumpy and a little bit more cynical. And as I said, not that we know of any cynical or grumpy anaesthetists, but having a bit, I think, to the point that Emma made earlier, have a bit of time and space and tools to help you develop, as well as goals and outcomes to work to that are personal to you. I think it's really useful in developing, you know, ourselves. And we talk a lot in the NHS about investing in each other, but then when it comes down to it, a lot of the time it's how many patients you've seen, how many people are on your operating list. And so I think, and there's many other initiatives like CLEAR out in the wider space of the NHS. And I think the more support we can give colleagues to engage in this kind of work, I think the better the NHS will be, not just for its staff, but for its patients. Okay. Brilliant. Well, on that note, appreciate I had to wrap up pretty quickly on the last end, but I just want to say a huge thank you for everyone for their time. If anyone does have any thoughts or questions, please do drop us an email or drop us a line. And I hope everyone has a great Friday and weekend when it comes.